Acute myeloid leukemia is an aggressive, potentially lethal cancer involving the blood and bone marrow, and particularly the myeloid precursors. Let's say it's late at night, or oftentimes the middle of night, you get a call from the emergency room that a patient has been sent here from his primary care physician's office or a local emergency room. He presented after significant bleeding or an infection of his teeth following a dentist appointment a few days prior. They had done a blood count check in the emergency room and done some test of his metabolic panel, found that his white count was elevated at 50,000 with circulating immature cells. We send the blood at our hospital generally for flow cytometry. And flow cytometry can be expedited or rushed, so you can have a rapid result, hopefully the next day. We also, at our hospital now, have a rapid mutational test. We didn't have this previously, we have this now. If there is a circulating blast population, we can send that rapid test off to blood too, and that can return in 1 to 2 days.
So for cases where acute leukemia is suspected, at least in my institution, in my practice, we usually receive a rash page saying suspected acute leukemia, and that rash page is received by both pathologists, by the core laboratory, the hematology laboratory, by the flow cytometry laboratory. So everyone is alerted there is a specimen that needs, to be prioritized. The pathologist will try to review either the peripheral blood or the bone marrow aspirate, within the hour or the couple of hours after the rash page. And at that point, if the pathologist agrees that there is an acute leukemia, we often initiate also the ultra-rapid NGS testing. Some type of NGS requires still quite some hands-on time and sort of more skilled technologists to set up the assay, and then require bioinformatician for the analysis. But the ultra-rapid NGS, for example, we have implemented has really minimal hands-on time and does not require a skilled technologist to set up the assay. Also, the assay already performs also the analysis, so it does not require also a bioinformatician to generate a report to review the test results. So from that point of view, we sort of frees up the techs in the laboratory to perform more manual assays. The ultra-rapid NGS certainly has had a big impact. Many times we are able to test patients with suspected acute leukemias where they are still in the emergency room, and by the time they reach the floor, because a bed has become available, we already have genetic results back, which means we can give a much more specific and informative report to our oncologist, and they can sort of start treating the patient right away. I think the patient have been happier not having to wait a long time for their final diagnosis and to start treatment. And the oncologists also are not wasting any time, and starting treatment sooner may mean also that the patient can leave the hospital sooner, and therefore that another patient can also be admitted.
One of the biggest challenges in healthcare right now is bed utilization. Every time I walk into my hospital these days, the emergency room is packed. The hospital rooms are often taken. It's hard for patients to sort of go through and get the care that they need on the hospital floors. To be able to start treatment sooner, to understand what the disease is sooner, also means that patients can leave the hospital sooner. That has, in my view, huge implications for the practice, at least at our hospital.
I certainly think that having NGS in-house is key to having a rapid turnaround time, and certainly having also a great communication with the oncologist for which patient it's necessary to have rapid results. Having this conversation with the oncologist where it really does matter, I think is key, and many times also informing them whether or not they need to pursue additional testing.
It helps to have an in-house hematopathology team because you can pick up the phone and discuss the case. Having to have a pathology team outside your hospital whom you don't know, who may change all the time, to have to wait a week, 2 weeks, 3 weeks for a result, that obviously would be much less desirable. The availability of rapid testing has been a game changer for us. We, within 2 to 3 days, have a general idea of what the disease is, and that helps us plan. It helps us reach out to the patient's insurance, get prior approval of authorization if needed, get the drug in hand, because many of these drugs are expensive and not necessarily on inpatient formularies. If they're candidates for clinical trials, this is a huge advance because you can make a determination to consent and enroll a patient. And I always tell patients, there is not much I can do to take away the sting and the pain and the trauma of a new diagnosis of AML. But what often makes things easier as you move forward is information. So the more you know, and the more you understand the plan, and the more concrete that plan is, the better you feel. So certainly having that information sooner, earlier, having the ability to make a plan and a strategy for the management of the disease, I think overall makes everybody comfortable.